Got it. There we go. All right. For some reason, it wasn't recording. There's not a lecture for this. This is out of your Daniels and Worthingham's manual muscle. This is the manual muscle testing book. The other stuff we're going to talk about is going to be out of your goniometry book. They should be both your spiral bound books. This goes with the lecture we already talked about. So this goes with the knee and hip lecture. So I don't have a specific lecture for this. This would normally be done in the lab. I'm going to do the intro to the lab portion, and then we're going to go ahead and do the lab when you guys are on campus. So here's the deal with the knee, because we're going to start with the knee. There are only two motions that you really have to worry about manual muscle testing. What two motions do you think they are? I'll give you a hint. There's really only two motions in the knee that we can test. Flexion, extension, exactly, right? So with that, the only thing you have to think about is what pattern those occur in. So what plane does flexion and extension occur in? Does it occur in the frontal, sagittal, or transverse plane? Good, sagittal, right? Good. All right, so once we have that down pat, that's going to be important for when we get to the part where we're talking about gravity eliminated. So we're going to start with knee flexion. I've got that brought up here. We are only going to worry about knee flexion in aggregate, meaning gross manual muscle testing of the knee. And why do we do that? Because we can actually test the specific muscles of the knee for flexion by putting the knee and the hip in different positions. But almost never do we do that in physical therapy because the hamstrings themselves work in concert. It's not like if, biceps femoris decides not to work, the others aren't going to work. They work in really heavy concert with each other. So we want to make sure that we're testing them as a group, not necessarily each individual muscle. The only time we would test them in each individual muscle is maybe if we're working with a spinal cord injury patient. And I've done that. But then again, that's also because I was working in a spinal cord injury center. And then you get kind of specialized training on that. You kind of reassess. What I did was I went back to this book and started reading again. I still have my book of it over there somewhere, from when I was in school, and I'm pretty sure I've got the -1 edition. I forget what edition this is, but it's whatever edition it says. And for those of you that don't know, inside your book, you should have a code that you can get this digital version of the book. The nice thing is you can add emoji reactions to your chapters. I don't know why they did that, but whatever. So we're going to start with flexion. So the first thing you have to understand, exactly. First thing you have to understand is we have to go back over the grades, right? So we have to go over the grades of manual muscle testing again. And if you remember, what color I had? Purple, that's good. Those are our grades of manual muscle testing. Oh, and 0. 0 means no contraction. I'm going to start from 3, and then we're going to go off of 3. So manual muscle test grade 3 means they are able to perform full range of motion with gravity. I got to spread this out. So you're able to pull full range of motion with gravity. Now this is interesting because this is where it gets a little weird. Because technically, if you don't have full range of motion, you can never be a 3. So a lot of us would never be a 3. We would probably be a 2+ or something weird like that. That doesn't happen in the real world. I'm going to tell you that. This is only a book thing. If you can perform most of the range of motion, maybe you only have 105 degrees of knee flexion against gravity, you're going to get a 3. Okay, so I just want to warn you, the book will say full range of motion, a little different than real world, right? Now your tests, like your boards and my tests, aren't going to trick you and say that the patient only has 103 degrees of knee flexion, but is able to lift that leg against gravity. I'm not going to do that to you. If I give you a test question, it's going to be something along the lines of, your patient is performing knee flexion in the prone position and is able to move their leg into knee flexion through their available range of motion against gravity. What muscle grade would they attain? What muscle grade would they attain at that point? So through their full range of motion in the prone position against gravity. That automatically gives them a 3. Okay? You need to understand 3 because 3 is kind of the jump point for everything. So we see this little lady here. I think she's got the person in the prone position. He looks so happy and comfortable. And she's testing his manual muscle testing. So the first thing we're going to do is put them in prone and say, okay, what I want you to do is I want you to bring your leg all the way back to your backside and then back out. And then you're going to move them passively through the motion. That is a key thing for manual muscle testing and for range of motion. You have to passively move them through the range of motion. If you're going to do both at the same time, you're going to do knee flexion, knee extension, whatever, you have to move them through both. So in this case, you're going to let them move through that available range of motion, look at it, and then go, okay, now you do it. They're going to kick back, and they bring it the whole way through the range of motion. At this point, gravity is going down, like that little picture, that little arrow. So they are going against gravity. The next step for us, if they're able to attain full range of motion with gravity, is to apply manual resistance. And as you can see here, she's got herself properly stabilized and is applying, I would say her body mechanics aren't the best, but those shoulders are way off. But what you're going to do is you're going to stabilize the upper femur in order to keep them from being able to cheat with the hips. So a lot of times, and I'll be honest, a lot of times when I'm doing this, I'm right up under the gluteal fold or I'm right on the ischial tuberosity. And what my goal is to keep them from hip hiking to try to cheat and use some of their glute. And then the patient is going to do the motion again. They're going to go all the way up, and we're going to have them come to about midway back down, which is, if you can see, he's about midway between fully flexed and not flexed. You are then going to apply resistance just distal to the calf. So you're not going to put it on the calf. You're not going to put it on the heel because, again, the heel is going to create way longer lever arm, and it's going to make it harder for the patient. I usually go right below the big heads of the gastroc, and that's where I apply my pressure. And you're going to apply pressure in a downward motion. And the patient's job is to what? What do you think? Flex, mainly, resist. Exactly. So what I'm going to tell them is, don't let me push your leg down. Or keep pulling your leg up. Bend your knee again. Whatever you want. I typically say, don't let me push your leg down because that's a very, very clear, again, you're going to find my commands are very, very simple. I've worked in Nevada. I know they have to be simple. Don't let me push your leg down. We're going to apply resistance. What are we going to start doing as soon as we start applying resistance? Do you remember that from our manual muscle testing lecture? We're going to add a moderate amount of resistance, right? And then we're going to start counting. How long do we have to count when we're doing the manual muscle testing? Yeah, so 5 seconds, right? So 1 Mississippi, 2 Mississippi, 3 Mississippi, 4 Mississippi, 5 Mississippi. If they are able to hold against moderate resistance for 5 seconds, what grade do they get? Yes. Nope, they already got a 3. 3 is against gravity. Going the wrong way. Keep going. If they're able to hold against 5 seconds, 5. Good. So 5 is able to perform full range of motion and resist moderate resistance for 5 seconds. Let's spread this back out a little bit more here. So I'm guessing that some of you didn't go back and watch that video yet. So go ahead and do that. Now, because this is what my test was. I was curious as to how many of you guys actually watched that video for the day that we were off. We gotta go back and watch that a little bit. Now, if you're putting pressure on, you're counting to 5, and somewhere in that 5, they lose grip, meaning they're not able to resist you and they drop a little bit. What does that make it? So say yes, 4 is, again, able to perform full range of motion and resist moderate, that was bad spelling, but breaks. And now understand, this is not literally like Dylan grabs a hold of the person's calf and pushes down and breaks their knee. This is at the point that you feel them losing resistance, we let off. That's a 4. Because you don't want to jam their leg all the way back down to the table. Right? Now, if you start them up there, they get full range of motion against gravity. You start putting resistance down, and they're not able to resist at all. They go automatically down. They're a 3. There are plus and minus grades for 3 and 4 and 5. We're not going to talk about those. We don't use those in the clinic. I'm going to tell you that straight up. We don't. Now, if you find out one, you're going to find out one clinic. One of you is going to go out in the clinicals, and you're going to say, Mr. McKeever, this clinic that I worked at uses the plus and minus. Well, they're silly because those pluses and minuses are extremely subjective. And on top of that, I'm going to tell you most clinics don't. And if you do find one of those clinics, your manual muscle testing book has all the grades in them for those. So go back to that. All right, so let's go through those 3 grades again. First thing you're going to have them do, move it through full range of motion against gravity. They're able to move against full range of motion against gravity, automatically a 3. You're going to apply resistance going down as they're coming up. If they're able to hold it only for a few seconds and then break, that's a 4. If they're able to hold it for 5 Mississippi, that's a 5. Does that make sense to everyone? Because we got to get those in order to understand 2s and 1s. Does that make sense at least? It does make sense, Mr. McKeever. Okay, good. Then let's say you have them in prone position and they are unable to go through full range of motion. At that point, you have to move them into gravity reduced position. I like to take gravity reduced because you never eliminate gravity. So they call it gravity eliminated position, but it's gravity reduced. We learned in physics, gravity is not an option, right? Despite what flat earthers say. So what if you have a patient that is in the sagittal plane for motion, which is what flexion extension is in, you're going to move them into the frontal plane for reduced gravity. So at that point, you're going to move them into side lying. Because in side lying, I think I've got the picture of that coming up here. It's not going to let me. I'll go forward in a second. In side lying, you're no longer going against gravity. You're just going side to side, right? Front and back kind of with that knee. So if they're able to partially lift against gravity, so they're able to get their foot maybe off the mat, but can't get full range of motion, but then you lay them side lying and they're able to get full range of motion with gravity eliminated, that is a 2+. These are the only pluses we're going to use. So partial ROM, I can't do the C, so we'll do that. Does that make sense for everyone? So they're only able to get a little bit of motion going on with gravity. You lay them side lying and they get full knee flexion. That's a 2+. 2, can I do a plus? All right, 2+, close enough. 2 crossing my fingers. No range of motion with gravity. Full range of motion with gravity. All right, so a 2 is you ask them to lift against gravity and they're like, I can't. It's not happening. And then you move them into side lying and they're able to move through their full range of motion with gravity eliminated. That is a 2. And we're going to go over these grades every time we do these joints. So you're going to have this beat into your head by the time we're done here. So don't, if you're freaking out right now going, how the hell am I going to remember any of this? By the time we get to the end, this will just be, you'll be able to, like, literally I'll go, gravity eliminated, full range of motion, partial range of motion with gravity. You go, 2+. It'll just come out of you. Trust me. The other class was like, they said the end of the semester, they were like dreaming about doing manual muscle testing. That's fantastic. So 2- means partial range of motion, gravity limited. So they're not able to go through full range of motion, but they got something going on. So maybe they can do 25 degrees. Great, that's a 2-. Does anyone remember what a 1 was? Yes, good. It's either a twitch or a spasm. I don't know what that, or spams. A twitch or a spasm is a 1. So, love mystery meat, right? Did you know that Spam made like a ton of stuff during World War II because that's when they came out, and they released it all to the stores. And with the advancement of COVID, they finally had to make a second batch. It was a joke. I thought it was funny. All right. So, if we're doing knee flexion, where are we going to palpate for that twitch? Looking at this lady, yes, right. Looking at this lady, it would be where her left hand is. And when I've got a person that's only a twitch, especially like a spinal cord injury patient, I'm going to palpate both origin and insertion. So I'm going to kind of put my hands, and then I'll test muscle body as well, because we want to try to give them some hope, right? If we can get a twitch, we can do something. Not much maybe sometimes, but at least a twitch is better than the last, which is no contraction at all. A twitch says there's some neuro stuff going on. If we've got nothing, I hate to say it, there's probably nothing we're going to be able to do for them. If we've got no contraction whatsoever, we can't even get a twitch or a spasm going on, there's not much we can do. I love that. This is one of the key things. Most textbooks will say that FES and NMES, so functional electrical stimulation, neuromuscular electrical stimulation, are only good if you are 2- or above. Some books will say we can get something out of a 1. I don't totally believe that, but most of the studies show if you can get a 2, if your patient's got a 2-, meaning they've got partial range of motion, gravity eliminated, they will be able to get something out of doing Russian. If they're a 1 or a 0, it's not likely they're going to get a lot out of Russian. So that's the thing, is we want to give them hope. Doesn't mean that a 1 won't get better. I'm not saying that, but a lot of times when you see the 1s, they're on their way to 0s. It's in my personal experience and anecdotally, I can say that most of the 1s I've encountered go backwards, not forwards, and that's a bad sign, right? That usually means they've got nerve impingement, nerve damage, something like that, like we talked about last class. Does everyone understand at least the grading system? Again, we are going to go over this every single time. I'm actually going to copy this because that's a really good. Let me get up here real quick. That is a really good way of writing it out, and I don't feel like writing it out every time. Yeah, where to work. I'm going to copy. I'm going to paste that over here as well. So there they are, saved for you guys. Go away. We're going to clear it out here. I'm going to close that. All right. So now we're going to talk about the actual testing. Now that we understand the grades, we're going to talk about testing. For knee flexion, we're going to put them in prone. They're going to bend their knee up against their butt. We got 3. Bend their knee up. We're going to put pressure. They break. 4. Pressure. 5 Mississippi. Don't break. 5. If we go to 2, we're going to go sideline. And they're going to have the leg that we're testing on top. Bend back. And I'm going to kind of go through the motions here for each of these. Does that make sense? The actual positioning for these. So let me see if I got shorts on because I know I'm going to be doing demonstrations here. So let's see if I can. So if I'm lying down, let's see if you can see me. You can. I do full range of motion and go back down without losing any strength. That is a 3. I come up. You're going to tell me go back a little bit. Then you're going to push my leg down and tell me, don't let me push you down. And I break. That's a 4. You tell me don't push you down. I hold for 5 Mississippi. Okay, good. That's a 5. I can't do full range of motion against gravity. I'm going to go into sideline with the leg you're testing up. And you're going to have me move like that. Right? So if I have some gravity or some motion with gravity, full range of motion without gravity, 2 plus. If I have no motion, my gosh, no motion with gravity, full range, like no gravity, 2. If I've only got a little bit with no gravity, that's a 2 minus. And then 1 is you palpate and you feel it quiver. Whew. That was why I did it. My hammies needed it anyway. All right, so like I said, there are special testing here that you can do for semimembranous, semitendinosus. Aggregate is all we want. Okay, so don't worry about these here for your testing or anything like that. The only one you want is in aggregate. So here she's doing a grade 2, and then grade 1, right, testing for motion. So watch for substitution. Again, if you feel their hip picking up, they're substituting. If you see them go into plantar flexion, they might also be substituting. Why? What are they trying to use to flex the knee? If you see a rapid plantar flexion and then the knee starts to move, they're probably trying to do they're doing a reverse muscle action with the calves. So their foot should just kind of be relaxed. I wish mine was relaxed, but my calves are tight. Does flexion make sense? Okay, let's move on to extension. Extension is a ton easier. And they got all these pretty pictures for you too. It's awesome. Knee extension, you're going to have the patient sitting. What type of an exercise am I doing when I'm doing this? From our exercise class the other day. It's an open chain, good. Long arc quad, good, right? So you're going to tell me if I'm your patient, okay, Mr. Patient, we're going to test that right leg. What I want you to do is I want you to, and you're sitting beside me, you show me. You're going to kick your leg up like this. The next thing you're going to do is come over to me, and what's the next thing you're going to do? After you've shown me, you're going to passively move me through it. Boom. Okay, that's what I want you to do. All right, 3, 2, 1, Mr. McKeever, kick your leg up for me. I'm able to go full range of motion, get my knee locked out against gravity. What grade am I? 3, yes. We're all 3s at that point. The next thing you're going to do is come along and you're going to say, okay, I'm going to put some pressure on. So you're going to stabilize either at the hip or up on the shoulders, depending upon what's happening. If I'm on the edge of the mat like this and I'm kicking up, you may want to stabilize me on the shoulders if you're worried about me being balance challenged, okay? If not, at least stabilize at the hip, right? So I tend to stabilize with my left and test with my right. If you want to test the other way, it doesn't matter. If you want to come in here like this and go like that, doesn't matter what hand it is. You're just going to stabilize with one hand, resist with the other. So you're going to come out just above the ankle, and you're going to apply a downward force. The key thing here, though, is just like with the hamstrings, you're going to have me kick up and then relax slightly. Why do we want to get them to relax slightly, do you think? What could I use in this position to resist you pushing me down? What mechanism? In the knee. Yeah, the screw home mechanism, right? I could lock, because right now, boom, I've got that knee completely locked in. I've got that femur and that tibia locked in place. If you try to push me down at this point, you're really fighting the bone lock, not fighting the muscles. So you're going to say, okay, Mr. McKeever, relax just a little bit. Now, I'm going to put pressure going downwards. Don't let me push you down. Oh, you start counting. 1 Mississippi, 2 Mississippi, and I drop to the floor. What grade am I? 4. Good. Now I'm up here. 1 Mississippi, 2 Mississippi, 3 Mississippi, 4 Mississippi, 5 Mississippi. and I don't move, and I'm like a rock. Urgh. Now we got 5. Good. So we got those so far, right? Next, we're going to move into gravity eliminated, right? Gravity eliminated, we're going to go back to sideline. So I'm going to lay sideline. You can either choose to support the leg, or if you just want to let it there, right? Bring them back a little bit into flexion and say, extend the knee. All right. I'm able to get full range of motion. I had partial range of motion against gravity, full range of motion with gravity eliminated. What am I? 2+. We're all getting an A+ for this lecture. Now, I had no motion with gravity. I have full range of motion against gravity. Now I'm 2. Good, Dylan's got this. And Dylan can't answer the next one. Somebody else has got to answer it. Now you bring me back into flexion, you tell me to extend my knee, and I only go about 15 degrees. What am I now? 2-. Good. The last phase is the 1. Where are you going to want to palpate for your 1? I'll talk about that in a second, Renee. You're 7. I love it. Where would you want to palpate for the trace? Yeah, right across the big belly of the quads, right? And if you're just coming across that big belly, you're going to get all 4 of the muscles. So I lay my hand broadside across it. And a lot of times I'm going to put one of my hands up here at the ASIS as well, because you can really feel when those tendons kind of quiver. So I'll say I'm going to palpate just below that big hip bone, and I'm going to put my hand right here. Try to straighten that knee out. So Renee asked a great question. Are we going to hold the leg up like that? You can. It does make it easier. I will tell you that. It makes it easier on the patient because now you've eliminated the friction between the legs. But you're going to find most clinicians don't. Most clinicians will just take and put a pillow between their knees, and that's how they'll hold the leg up. Especially probably, I'm guessing, nowadays when we're trying to minimize physical contact. I'm guessing they're probably not doing as much touching and holding as they would normally. But you can do it either way. It's not a wrong way if you don't hold the leg up. And like if you're, like Renee, I'm going to use an example. If you're holding my leg up, you're going to get tired. I mean, my leg is probably, one leg's 90% of my weight, the other leg's 90% of my weight, and then the rest of my body's 90% of my weight. I'm 270% of my weight. Yeah, I did math. So does knee extension make sense then? That's right, leave. No, just kidding. Okay, good. So the next thing we're going to talk about is the goniometry. And for some reason, they locked me out of my goniometry book, so I'm just going to have to demonstrate and let you know that it is in your goniometry book. I don't know why they locked me out of it. F.A. Davis is having a fit, I guess. So this is what type of a goniometer? Yeah, manual or a biggin. It's a biggin goniometer, right? We do not size shame our goniometers, though. I'm just saying. They get really, there's a bigly goniometer. They get really kind of sensitive about being, about size shamed. So this is just the knee goniometer. No, just kidding. I'm just joking about that. All right. So it doesn't matter if we are testing knee flexion or knee extension. Our landmarks for goniometry are going to remain the same. Okay? The first thing we have to find is our vertex. And our vertex is going to go through, let me get my pen here. It's going to go through our goniometer, right? What did I say is our vertex for knee flexion extension? Do you remember from the lecture? Lateral epicondyle, good, right? So we're going to have to get here. First thing you do before you even pick this up, put that down. You're going to get hands-on with the patient. He's got his game on today, I know. It's that whole Angels comment. You're going to get hands-on. I'm going to say, okay, Mr. or Mrs. Patient, I'm going to go up here and palpate your big hip bone. What hip bone are we palpating up here? We're palpating our greater trochanter. Okay, I found that. Now I'm going to come down. I'm going to find that lateral epicondyle. I find moving, if they have shorts out of the way, it's a little easier to find. If you can't find the greater troch, what could you have them do to their shorts? Maybe they've got too much clothing here. Move it down. Yeah, have them pull it down. I'm not going to pull my shorts down for you guys. Sorry. Pull it down. I know, Jared. I know you've been hoping for this all day. You're going to have them pull it down slightly so you can get skin on skin. I will say with Dr. Vreskin, she's very particular about this. When you are palpating, you want to palpate on skin if possible. Does that make sense? I want to warn you about that. It's not a negative warning. It's just she is really, really stringent about this. If you can get skin on skin, she wants you skin on skin for palpations. Even if it's the ASIS and you have to kind of pull their shorts a little bit down to find those ASISs. So I found my greater troch, find my lateral epi, and my final palpation, there we go. Look, I have feet, is my lateral epicondyle. So then you're going to take your goniometer, this one that moves with the big fat part of the goniometer is called your stationary arm. You're going to line up the little hole in your stationary arm with your greater troch. And now it's not like you're going to put it up here, because if I put it up here, the circle part doesn't. If I make it full screen, you mean bring it down some? Oh, you want me? I got you. Yep, let me do that. I'll stop sharing. I understand what you mean now. There, is that better? Okay, good. So I'm going to stand up here, right? So there's my greater troch. You don't want to put that dot there because look how high up the actual vertex is. What you're going to line up to start with is just your vertex. So I'm going to come down here, find my lateral epicondyle. I'm going to put that vertex on that lateral epicondyle. I'm going to palpate and line up my dot and line with the greater troch. Most of the time, what you're going to be lining it up with is the midline of the femur. Does that make sense? Because if you look and you go from that lateral epi up here to your greater troch, it's right along the midline of the femur. Same thing then. If this is the stationary arm, what is this one called again? It is the not stationary arm, right? If you're not stationary, you are moving. There we go. So this is the movement arm. Then you've got it lined up with that lateral, I gotta stand up again, lateral epi. You're gonna line up that bottom one with my lateral malleoli. Do you understand at least lining up the goniometer? Because whether we're doing hip flexion knee flexion or knee extension, we're lining up exactly the same. All right, good. So I got about 15 minutes here. So for knee flexion, you would think for range of motion, you're going to test the patient in prone. You're wrong. And I was wrong. I did it wrong for a good bit of my career, evidently. But you will find in the clinic, we all have cheater ways how to measure. I measure my knee flexion and seat it, because I try to minimize my patient moving around as much as possible. But the way you're going to measure knee flexion is in supine. Remember, when we're measuring range of motion, we really don't care what their strength is. All we're looking at is how far they can move. So you're going to have your patient lie down in supine. I'm going to try to get a place where you guys can see me. Nope, not that way. That way works. Have me lie down in supine, hook lie the opposite leg. And then you're going to tell me this is what we're going to do. We're going to move your knee up like that. They're going to keep their foot about 4 to 6 inches off the ground. So you're going to line up the goniometer here. You're going to move me through it. You're going to estimate what my range of motion is. So everyone take a guess. What's my range of motion of my knee? Looking at that. How many degrees? Okay, I'll check the numbers when you back up there. So I'm blind. Then you're going to have me, you're going to say, okay, Mr. Patient, I need you to do that now. So you're going to have me move through. Boom. When I get to here, you'll say, hold it. And then you're going to line the points up again and get your motion. Yeah, I'm about 105 to 110, depending on a good day. I definitely have a soft end feel. All right, so again, because I'm going to be getting on the floor here in a second, I'm not moving my chair. You're going to tell them what they're going to do, right? I oftentimes will stand up and just say, you're going to be picking your leg up like this while you're lying down. Patient gets it. Good. You're going to move them through that passive range of motion so they understand what they're doing, so you can estimate the range of motion, and also so you can get the end feel. With knee flexion, there are only two end feels you should really feel that are normal. What are those two end feels? Not hard, soft and springy or firm. Good. Because you should either have the tissues banging against each other, and that's your soft end feel, or your quads don't go any further, and that's a firm end feel. Or springy is another term for it. It's okay. That's why we go over this, Erica. Don't freak out. By the time you graduate, you'll have gotten this. All right. So we move them through passively. Then we have them do it. Your landmarks are going to move on you. There's just no way they're going to line up perfectly. You can stay with them the whole way. I've never seen a therapist that's like, oh, I'm good. You're going to have to palpate a little and make sure you're kind of still in line with those landmarks, okay? Just go, okay, hold on a second. Okay, there, I'm lined up. And then you're going to read, okay, Mr. Johnson, okay, I see that you're at 125 degrees today. Why are we measuring range of motion again? What are we trying to compare it to? We're going to compare it to the way a good side, right? And then we're also going to compare it to what the PT did, which is the evaluation. Good, right? So we often call this, we're comparing it to baseline. Baseline is where the eval started, or the re-eval, right? Because their baseline is going to constantly move as they improve. So does that make sense for knee flexion range of motion? And then you're going to say, well, Mr. McKeever, I see some therapists in the hospital measuring it like this. Okay, great. What they're doing is taking a shortcut. That's okay. You'll find, here's the deal, you'll find when you guys are out in the clinics, one of the things I'm going to say when you guys come back from your last clinic and I'm getting you guys ready for the test is everything you just learned at clinic, for the most part, forget about. Because you're going to learn not bad habits, but just not book habits to doing things. Does that make sense? I'm going to try to prepare you from the book side of things. And the reason, so why supine not prone? Because when you're in prone, you can't get that vertex right on that lateral epicondyle. Unless you get one of the flat goniometers, then you can. And there's no reason, theoretically, you couldn't do it prone. But the correct way for the book, for the actual, when they say the AAOMS, I think is the Associate Academy Manual Specialist or something like that, they chose supine. And so you'll find that a lot of times it's the specialists that choose the position we do it in, and we just say, yes, I agree with you. So that's knee flexion. I got 10 minutes to get through knee extension. Knee extension is very easy. If you've got knee flexion down, knee extension is easy. Now you're going to roll them over into supine. So you're going to lay them in supine. You need a pillow or a roll, because you're going to place this, where do you think? We're going to pretend not under the knee, because that's not going to let me extend. Because right now, if I just lay my leg down, I can't go into full extension. Yes, under the heel or calf, right? So I'm going to put this down here. We're going to pretend that I'm in supine so that I can show you guys. So now my calf's off the mat. That is what you need to get. So what I like to do to make sure I'm there is I just take the goniometer and see if I can slip it under their calf. Or your hand, doesn't matter. I tend to use the goniometer just to see, because if I come in here and, I can't straighten anymore. If I come in here and I can't get the goniometer under the calf, you can't see that, but I can. At that point, you know that you don't have it high enough. You need to have it high enough that you have space under the calf. You're going to tell the patient, okay, so what we're going to do is we're going to let your knee drop. And what type of an exercise are you going to have them do you think? If I'm just going to push the knee straight down, that is a terminal knee extension or a quad set. Either one of terms you can use, right? Push it down. Okay, so I'm going to move it. There's my passive range of motion. I'm going to kind of eyeball it. I know that I've got about 4 degrees of extension lag. So, okay, eyeball it. And then you're going to tell the patient, okay, I'm lining up with those landmarks. I'm lined up. 3, 2, 1, go down. Line them up again and get where your patient is.
Yeah, I'll put it in my backpack.
Okay, hold on. Let me turn you up so I can hear you here. Oh, Tyler's just came back and is not on mute. We'll mute. There we go. Tyler likes to invite us into his world. Does that make sense, at least the positioning? So supine, a roll under the heel to allow that calf to be lifted off so the patient can actually push down. The main reason for that, oh, you're fine, Tyler, I just like picking on you. The main reason for that is so that you can allow that knee to extend, or if somebody's got hyperextension, yes, supine for both flexion and extension. The only reason I say roll is because your flexion for the flexion exercise is in prone. Where is I going? Oh yeah, the pillow. You need to let them go into hyperextension if they have hyperextension. So now I'm going to talk about grading it real quick or typing up your note for it. I'm just going to use the chat here for this. So if your patient, like me, my range of motion is about 4 degrees of extension lag and about, we're going to say 110 degrees of flexion. You would document that by saying, I am 4 to 110. Does that make sense? Because 4 degrees says, it doesn't say that I have 4 degrees of extension. It says that I am missing 4 degrees of extension. I'm starting at about 4 degrees, going to 110. That's my range of motion of my knee. If I put it as that way, 4 degrees, 0 degrees, 110 degrees, what does that indicate? Now what does that 4 degrees indicate? Yeah, so I have 4 degrees of hyperextension in this case. I can get to neutral, and then I have 110 degrees of flexion. So if I just say 410, it just means I'm stuck. So what could be a reason I'm stuck in 4 degrees of flexion? What's probably tight? Yeah, tight hammies and tight calves. Just is, right? Now, here's the thing. When you get that, if you have a patient like me, I'm stuck in 4 degrees of hyperextension or flexion. If it doesn't affect my gait, causes no problems for me walking around, it's not a pathology per se, right? It's not causing me any negative effects. If it's causing me negative effects, then we got to stretch me out. And I still got to stretch out. I just don't like having that 4 degrees of lag because I know I'm eventually going to need knee replacements, and I don't want to start there already. So what if I was to say this? What would 0 to 90 indicate? What would 0 to 90 indicate at the knee? Right, I can't get past 90 degrees. Good. And that, again, we're testing. Yeah, I have no lag, meaning that my knee goes fully extended, and I can't bend past 90. That's going to be really common for our total knee replacements. Now, if I can only get 90 degrees, do I have functional range of motion? Yes, right? Because what do I need for walking again? Do you remember? About. Close, a little bit higher. A little bit higher. A little bit higher. 60. There we go. I saw it. So you need about 60 degrees, right? And then you need 90 to do what? I mean, you actually don't even need it for standing. No, for more importantly, going up and down stairs. Because sit to stand, I can always raise my chair up and still stand up. Right? There are ways we can teach them if they have lag how to stand, whether they have extension or flexion lag. So just a quick review before we cut you all loose. For manual muscle testing, when we are doing knee flexion, what position are they in? Prone. Good. Prone for knee flexion, manual muscle testing. That is the gravity plus position, right? Gravity is affecting them. If we need to gravity eliminate knee flexion, they go into sideline. Okay, and we're going to go over this like 50,000 times. So if you're not getting it, don't freak out. All right, knee extension manual muscle testing. Test against gravity, what position am I in? Sitting. Specifically, what type of sitting? Did you guys learn this yet in rehab? Short-seated, right? So short-seated is what we call when we're sitting like this. What's long-seated? Yeah. Long-seated is like this, the knee straight. So like when you're sitting up on a mat. So short-seated, you can do it in a chair or at edge of mat. And then we're going to test up. Good, that's against gravity. If we have to eliminate gravity, we're going back to what position to remove gravity? Sideline, good. All right, so that's for manual muscle testing. For goniometry, what position are we in? For whether it's flexion or extension? Supine, good. Good, 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 you got it. Now again, does that mean I can't test it and seated? No, absolutely not. And if you're an experienced clinician, you'll find ways to not necessarily cheat, but to make things a little bit easier for you. Like Dr. Naveska and I talked, both of us pretty much do, because she's my lab assistant for Therex, both of us in the clinic have done knee flexion and seated. But the book says you do it in supine, so we do it in supine, because that's what they say. And they know better than us. I don't know. All right, so how's everyone feel with that? And again, we're going to do a quick overview of it again tomorrow when we start with the hip, because you're going to find a lot of the hip motions are very similar to the knee. It's all right overall. And again, we're going to review it, and we're going to hit it again and again till the end of the semester when we actually get on it. So what I would suggest you do, just as a kind of a thing, some point today, or maybe even if you go into the clinic, you don't have to, or if you go into school, you don't have to do this now, because I think Dr. O'Neill is going to work with you guys on other stuff. But take one of your family members and do the manual muscle testing on them. Get your manual muscle testing book out, set it beside you, and just do the flexion extension manual muscle testing. If you want, when you get into if you go into school, if you ask Dr. O'Neill, you can sign out goniometers. We have a whole, you're getting the kit, yeah, it's going to take a little bit to order. It comes from corporate, and you know what happens when you order things from corporate. It takes a little bit to get there. But if you want to sign one out, you can sign one out. Dr. O'Neill can sign you one of these out. If you go in and she doesn't know where these are, the sign out goniometers, tell her they're in the locked cabinet. If you want to sign, you can sign a big one and a small one out. If you want to have one when we're talking, just so that you guys can kind of eyeball it with yourself. Ça va? Did okay? Are you okay? Bien. Ça va bien. Muy bien. Muy bien. All right, let's just switch languages left and right. All right, guys. I'm going to let you go, like I said, a little bit early so that those who want to make it into the lab, you can. Please drive safely out there. please wear a mask. Please, please. I know it's required, but still, please wear a mask. Wash your hands, foam in, foam out, all that good stuff. Check in at main campus before you go to lab. Okay? I'll cut you loose. Those of you going in, have a good day. I'll stick around here if anyone has questions. Those of you that have to go can bolt.
Hey, Mr. McKeever, I have a question.
Uh-huh.
Not school related at all.
That's okay. I get those questions too.
Randomly on my email,